Thanks for inviting me to talk about melanoma today. My name is Roger Olofsson Bagge. I'm an associate professor in surgery at Sahlgrenska University Hospital in Gothenburg, Sweden. And the agenda for today will be a short background, putting melanoma into a kind of more world perspective. We'll talk some about primary surgery, lymph node surgery, different local regional treatment options, as well as modern systemic treatment. And finally, some few words about how to treat surgically metastatic disease. So if we just start with the very basics, that melanoma is a malignant tumor caused by proliferation of melanocytes. And melanocytes are neural crest-derived pigment-producing cells, and we find them in epidermis, in the skin, in hair follicles, different mucosal surfaces, meninges, and also in the choroidal layer of the eye. And that means that in all of these parts we can actually develop melanoma, but today we'll stick to the skin. And the major risk factors for developing melanoma is ultraviolet radiation, and that is the very paramount risk factor, and it's especially UVB radiation, especially intense and intermittent sun exposure, sunburns, that is. It also increases dramatically with age. It also has a correlation to skin color, the number of congenital and acquired melanocytic nevi, albinism, and also to a lesser extent, but there are also high-risk genes, for example, CDKN2A and CDK4 and BAP1. And if we look at the incidence across the world, it looks like this. We have high incidence, North America, Europe, Scandinavian countries, and Australia. And if you see here, it says more than 5 per 100,000 persons. But there are also some in South America, South Africa, and Russia. But what we have to remember here is this number 5. Because if we look at the incidence in the Nordic countries, and this also goes, for example, for Australia, this is a short movie from the 70s, and in the 70s we had about 5 in the Nordic countries. But in the 90s we were up to 10, early 2000 up to 15, and now current day we have more than 20 per 100,000 in the Nordic country with melanoma. So it's a dramatically increasing incidence of melanoma in the Western world. If we look at mortality, then we can also see that the mortality is in North America, Europe, Scandinavian countries, and Australia. But there are also some mortality from melanoma, especially in Southern Africa and in South America. More interesting if we look at this, if we combine these two, the incidence and the mortality rates. Oceania, which is basically Australia, you have a very high incidence, but also some high mortality. Same goes for North America, Europe. But then you come down to South America, Caribbean, Africa, Asia. You see you have a low incidence, but a very high proportion of the patients with melanoma in these countries will actually die. And it comes down very much to income levels. High income countries have very high incidence of melanoma and also high rate of mortality. But in low income countries, you see almost all patients that actually get melanoma will also die from melanoma. And that is something to bear in mind. And I will come back a little bit later on why these differences are and how it comes. One important factor in this is melanin content in skin. And this is just to kind of widen the concepts a little bit. If you look at Caucasian skin, Asian skin, and black skin, you can see, of course, that you have more melanin content in the black skin. But in this paper, what they did was that they took biopsies from patients and then UV radiated them. And then they looked at cyclobutane pyrimidine dimers, CPDs. And that is basically these small mutations in the DNA where you get C to T substitutions. And we call that the UV fingerprint mutation. And this is to control the Caucasian skin. And you see how it flares up with these C to T or CPDs accumulating when you radiate a Caucasian skin, whereas if you have a black skin or an Asian skin, it becomes much less. So this is the kind of rationale why Caucasian or white people, they accumulate more DNA damage through the years, and that's why it increases with age. And if you look at incidence between different ethnicities, and this is US data, we all know that US have a mixed population. We can see that the Caucasian population in the US have a 22 per 100,000 people in incidence. Native Americans and Hispanic have about 4, whereas Asian, Pacific Islanders, Black have about 1. So there's obviously a greater proportion of Caucasian having melanoma, but there exists also in these groups. Here we have the age, the effect of age, where we see dramatic increase with age, and we can just think of that as accumulated mutations in the DNA. And if we now focus a little bit more on this cutaneous melanoma, to also explain a little bit of these differences, we have four major subgroups. The first one is superficial spreading melanoma. We have nodular melanoma, acral lentiginous melanoma, and lentigo maligna melanoma. And if we just start with the superficial spreading, that is intermittent sun exposure, Caucasians, middle-aged patients, people exactly like me actually going to Spain in the winter to get some sun. We have these moles, and they have a horizontal growth phase. And we have this ABCDE rule, A for asymmetry, B for border, C for color, and D for diameter, and E for that these moles are evolving. And all of these are characteristics of the superficial spreading melanoma. We have nodular melanoma, which is also caused by intermittent sun exposure, but instead of having this horizontal growth phase, they start growing vertical almost immediately. And there we have this EFG rule instead. So we just continue the alphabet here. So it's elevated, it's firm to the touch, hard, and they are growing. And these are commonly mistaken to not be melanomas, but because they don't have these ABCD rules, because they have regular borders, they are one color, and they are symmetrical. So these should not be missed for melanomas. And since they grow fast and vertical very fast, they can become invasive in just a few months. Then we have the lentigo maligna melanoma, and that is accumulated chronic sun damaged skin, especially in elderly patients in the face, and it starts as an irregular brown patch that grows into protruding, bleeding, and ulcerative lesion. And then finally, we have the very distinct type, the acral lentiginous melanoma, and that is on palms of the hands, soles of the feet, or the special version you can see here under the toenail, the subungual melanomas. And now comes to an interesting part of the world. I took 3 parts of the world. We start with Malawi, Southeast Africa. I found a very interesting paper, 106 patients at the center there. 98 of these patients had acral sites. So the extremely most predominant feature of melanoma in at least in this series in Africa were on acral sites. If we move to a paper from Singapore, and Singapore is an Asian country with a mixed population, 77% Chinese, 14% Malays, and 8% Indians. And then we can see that out of these patients, 77% occurred in the Chinese population. Actually, none Malay had melanoma in this cohort. 1 Indian. There were some imported Caucasians here. You can see Swiss, Norwegian, and French, and some Englishmen and Americans, and then a few Asians. But also here you can see that we have a mix. So here we have 50% of the patients with acral lentiginous melanoma, whereas 37% had superficial spreading melanoma. So here a little bit more mixed, but very common with acral lentiginous melanoma. If we move to Sweden, we can see here that this is from 1990s to current date. We can see that the incidence of superficial spreading melanoma is increasing from 60% to 70%. Nodular melanoma goes down from 20 to 10%, probably due to awareness. We have lentigo maligna slowly increasing, but here comes the interesting thing. Acral lentiginous melanoma is just a few percent, and that is very constant, it's going down. So in the Western world, what we have is a steep incidence, a rise in incidence of especially superficial spreading melanoma. And that is what differs the Western world from the rest of the world, where acral lentiginous melanoma is actually the most common melanoma. So now, with that kind of introduction, so to put melanoma into kind of world perspective, we move into what we should do with these patients. And we start with the primary surgery. And we start a little bit boring with staging. We stage melanoma according to AJCC 8th edition. And that is an American database. It started in 1998 and includes stage 1 to 3 patients and almost 50,000 patients in the database. And the database do actually contain patients not just from US but also from Australia and Europe. This is a very important slide to just have in the back of your brain about the prognosis for melanoma. If you have a stage 1 melanoma, your 15-year survival is very, very good, more than 80%. Whereas if you have a stage 4, it's very dismissive, maybe 5%. So it's a huge variation in outcome for patients with melanoma, depending on stage. And if you have a patient with a melanoma, what you do is that you do a diagnostic excision. You do it with a 2 millimeter margin. You just take it out basically with just a small incision as possible. And then you send it for pathological analysis. And the pathologist will give you a lot of data, but the two most important things are basically the Breslow thickness. And Breslow thickness is you measure from the top of the epidermis down to the deepest cancer cell in your material and measure that in millimeters. And the more millimeters you will have, the higher T stage you will get. I'll come to that in the next slide. The other thing you look for is ulceration. And here you have an example of an ulceration. You have an ulceration in the central part of your tumor, and here's how it looks in a microscope. Here we have epidermis, and suddenly you see the tumor coming out like this. And these two factors are the factors that make up the T stage. If you have a tumor with a Breslow thickness of less than 1 millimeter, you have a T1. If the Breslow thickness is between 1 and 2, you have a T2. If it's between 2 and 4, it's a T3. And if it's more than 4, it's a T4. And then you add this information about ulceration to get the substage. So T1A is without ulceration, T1B is with ulceration. And it just continues like that. So with these two parameters, you're able to say if it's a T3 melanoma, for example. And just this information will give you very good prognostic information. If you have a T1A, which is a thin melanoma without ulceration, you can see you have a 10-year survival of 98%. This is melanoma-specific survival. So extremely good. Whereas if you have a T4B, which is a thick melanoma, more than 4 millimeters with an ulceration, you have a survival of like 50%. So you cut that out, you get your diagnosis, and you know your T stage. What to do next? The next thing is to do wide local excision, and that is basically a safety margin to reduce recurrence. The question is, how much do you cut away? This has been discussed in the melanoma community for many years. We have to remember that when we started doing melanoma surgeries in the early 1900s, we used big margins, and we always did lymph node surgery to remove all the lymph nodes. So in the 50s, we did a lot of skin grafting, skin flaps, and amputations. But in the 70s, it started to kind of decrease the surgical morbidity, and we had margins between 3 and 5 centimeters. After that, starting in the 1980s, we had a total of 6 randomized trials. We don't have to go through these in details, but the randomized patients between 1 and 3, 2 and 4, 2 and 5, 2 and 5, 1 and 3, 2 and 4, etc. And if we put all of this information from these 6 randomized trials together, we have come up now with, there are differences in the interpretation, honestly, in different parts of the world, but I think most agree with the current European guidelines that if you have a Breslow thickness of less than 2 millimeter, you use 1 centimeter margin. If you have a Breslow thickness more than 2 millimeter, you use a 2 centimeter margin. There are now trials, for example, the MELMARK trial, or it's one trial, the MELMARK trial, that will actually randomize these patients with a Breslow thickness more than 1 millimeter to 1 or 2 centimeter margin to maybe finally answer the question if we actually need to do wider local excisions than 1 centimeter. But we have to wait many years before we have the answer to that question. Next question is, how do you actually measure this? And there's a plethora of different ways of measuring your margin. And this is what we recommend that you use. You have your linear scar of your previous diagnostic excision. You measure the central half of the scar, and then you measure radially your margin, which could be 1 or 2 centimeters like this. You make an oval mark, and then you taper the edges. If you do it like this, you will have good enough margin on the sides. If you measure the margin from the end of the scar, you will have much more margin on the ends, which is unnecessary. You just get bigger scars. So this is how we recommend if you have a linear scar. If you have a primary lesion or just a wound from the biopsy, then you just measure from the wound edges. And then you have a more or less round excision, which you, of course, taper around so you can suture it together. What we don't want is actually, let me put this way. If you have functional or cosmetic concerns concerning your outcome, especially if you're having an acral lentiginous melanoma, for example, there's perfectly okay with 1 centimeter margin. Or if you do amputations, if you have a subungual, you just go to the next joint. If you do wide excisions like this, you will end up with great morbidity, and you have to do a lot of plastic surgery to fix it. And this is not worth doing, actually. So stick to 1 centimeter margin, and you go down to the next anatomical layer, which most often is the fascia or periost. And that's what you can do. The second thing to consider is lymph node surgery. And the presence of lymph node metastasis correlates primarily with Breslow thickness and ulceration. And we categorize it as microscopic if it's clinically non-detected. That means that if we detect it by a sentinel node biopsy, we call it microscopic disease. If we can clinically detect it by palpation, for example, or an ultrasound, we call it microscopic disease. And then we have the third group, which is the satellite or in-transit metastasis. And I will come back to those. So this is an example of this, what we call clinical occult or microscopic disease. In other cancers, for example, breast cancer, microscopic disease are smaller tumor deposits less than 2 millimeters, but this we call everything that is detected by sentinel node biopsy is microscopic. And here you see, for example, small tumor nests within the lymph node. And here you, on the right side, you have the clinically detected or macroscopic disease. And this should then be palpable or clinically detected, and it can, of course, be quite small, but also very, very big. In transit is a special kind of metastasis, and it's a regional spread of tumor through the lymphatic vessels in the dermis or in the subcutaneous tissue. And we call them in transit because they are between the primary tumor and the regional nodal basin. So they are kind of traveling in transit from the tumor to the regional nodal basin. On the right side here, you see examples from a patient with a previous skin graft that now has several of these black in transit metastases. Previously, we defined them differently. You can have microsatellites, which is basically that you see that there are small satellite lesions within your pathological specimen. We can also have satellite metastases, which by definition should be within 2 centimeters from the primary tumor, or in transit, which are more than 2 centimeters away from the primary tumor. But nowadays, we kind of group these together because they are all within the same biological spectrum. We can call them in transit metastases. And on the right here, lower hand right here, you see that they actually have the same prognosis. It doesn't matter if you have microsatellites or in transit or both, they have more or less the exact same prognosis. And it's quite common for patients to develop these in-transit metastases. It depends very much, of course, on which patient group we look at, but up to 10% of patients can develop in transit, at least if they recur. So, clinical management. If you have your patients, you did your diagnostic excision, and you, of course, examine the patient and there is no suspected nodes, then you consider your patient for a wide local excision with 1 or 2 centimeter margin and a sentinel node biopsy. And the sentinel node biopsies is per definition the first lymph node to where the cancer is likely to spread. And by definition of this sentinel node concept, if we think, or it is like that the tumor spread first to the sentinel node before spreading to the other lymph nodes. And this is an example. You have a primary melanoma on the abdomen. We have to think of that each part of the skin actually have draining lymphatic channels that drains to specific lymph nodes. And in this case, there is a lymph node in the groin and 2 lymph nodes in the axilla. The way to find out which lymph nodes actually drains this piece of skin, we inject a blue dye or blue dye in combination with a radiocolloid, and then that will travel within the lymphatics and get trapped within the sentinel nodes, which will become blue and radioactive. And by using a scintillation probe, and we can identify them, and we remove them and send them for pathological examination. Here's an example, a very famous picture. You have the efferent vessel and your blue dyed lymph node. And with these lymph nodes, we have been thinking in the melanoma community concerning mainly 3 questions. The first, the prognostic value of a positive sentinel node. Does sentinel node biopsy in itself have a therapeutic value? And is there any benefit of a completion lymph node dissection in patients with a positive sentinel node? And I will try to go through them a little bit. There's one of these, or there's actually 2 seminal trials performed by Don Morton and his colleagues. The first one is the so-called MSLT1 trial. And in that trial, they randomized patients with melanoma to sentinel node biopsy, and if the sentinel node was positive, a completion lymph node dissection, meaning that they remove the rest of the lymph nodes in that basin, or just clinical follow-up. And from this, you can read out a lot of information. We start with this number 1 here. That is the blue and green curve. So in the observation group, if you didn't have any nodal recurrence, you had an excellent prognosis. And the same was in the sentinel node biopsy group. If that was negative and it was a true negative, you had an excellent outcome. We compare that with the yellow curve, which is the sentinel node positive group. And that is the comparison 2 here. Then they have a much worse outcome. And that means basically that by removing this node and saying if it's healthy or not, you can really say if the patient will have an excellent prognosis or not. So we can just, there are several other papers like this, but really showing that sentinel node biopsy, or the sentinel node status, is the most important prognostic factor in melanoma. But other thing, and this is much more highly disputed, is the therapeutic effect of the sentinel node biopsy itself. If we look at this, we're looking at disease-free survival. And in this randomized trial, this MSL-1, the observation group had a worse outcome than the sentinel node group. And that was because, of course, since you leave tumors left in the observation group, in both arms there were approximately 20% with that had tumors in their sentinel node. In the sentinel node group, we know that because we actually removed the sentinel nodes, and approximately 20% had the positive sentinel nodes. And the observation group, there was approximately 20% recurrences. So we think that that is the kind of the same patients. It's just that one we detect early, and the other patient in the observation group we detect late. But interestingly, there were no effect on survival between these two strategies. So we can really question the therapeutic effect of the sentinel node biopsy itself. But what they did, which is highly discussed and was not pre-planned, was they compared patients with a positive sentinel node, this is the yellow curve, and their survival, and they compared it with the observation arm that had a recurrence. And then they see that the probability of surviving this is much worse if you were in the observation group with a recurrence. But this is very speculative and can be argued in both ways, actually. But at least what they did was they continued very heroically with the MSLT2 trial, which were for those patients that actually had a positive sentinel node. Did we gain anything by actually doing a completion lymph node dissection? And this trial actually randomized these sentinel node positive patients to a completion lymph node dissection or just observation. And here we have at least a clear message that there was absolutely no survival benefit by doing a dissection for sentinel node positive patients. And there's actually a German trial, the DCOG-SLT trial, which is a similar design, sentinel node positive patients randomized in a similar way. And they couldn't show any difference on survival either. So in summary, we can say that the sentinel node status is the most important prognostic factor, and we recommend it for T2 or higher melanomas, in some cases also for T1b if there are high-risk features. Sentinel node biopsy by itself do probably not provide a survival benefit, and by doing a completion lymph node dissection in sentinel node positive patients, we do not add any survival benefit either. However, the sentinel node status will very likely decide on adjuvant treatments, and I will come back to adjuvant treatments a little bit further on. These sentinel node patients, we stage the lymphatic disease as well, and N1 is if you have one node, N2 if you have 2 or 3 nodes, and N3 4 or more nodes. And here is the same, N1A if it's sentinel node detected, B for clinically detected, and so on. But then we also have this, if you have in-transit metastasis, then you are a special category, the C category. And then is it N1C if you don't have any regional lymph nodes, and N2C and N3C depending on the amount of additional nodes you have. So N1A up to N3C is the N categories in the staging. And now it becomes complex because now you actually in the AJCC 8 you add your T category together with your N category, all of course M0, no metastatic disease, and then you end up with pathological stage 3A to 3D. And there's actually a color-coded chart to help you do this, and this is just to Google or save my presentation or print it. Basically, if you have low T scores and sentinel node detected disease, you're 3A. If you have a little bit more advanced nodal status, but still lower T stage, you're B. For all the rest, you're 3C, except if you have T4B lesions and advanced nodal status, then you're 3D. And all this discriminates this population quite well. Your 10-year survival for 3A is 88%, whereas it's 24% for a 3D patient. So if you now have a patient with a clinically suspected node, which is a macroscopic node, the recommendation is to verify that with a fine needle aspiration. You stage the patient with a CT thorax abdomen and an MRI of the brain, or PET-CT if you have that available. Then you consider a patient for a wide local excision with a 1 centimeter margin, and because 2 centimeters is not advisable in this case because you already have metastatic spread, at least to the lymph nodes. And then you consider the patient for an upfront lymphadenectomy together with your wide local excision, provided that your staging was negative, so the patient didn't have any metastatic disease. And just a quick kind of take on how we do dissection. So if we start with the neck dissection, for low volume disease, we do a selective neck dissection, and we base that on where you had your primary tumor. And next slide will show you a table for that. If you have bulky nodal disease, you do a modified radical neck. Only if there is extracapsular extension, you actually resect these classical neck structures. Otherwise, you leave them intact. And the aim is to retrieve at least 15 nodes. The modified radical neck is level 1 to 5, but you preserve the sternoclavicular muscle, internal jugular vein, and the cranial nerve 11th. And here you can see we don't have to go through it in detail, but for example, if you have your primary tumor site in the posterior neck, then you do your selective neck dissection level 2 to 5. Axillary dissection is also a little bit different from if you do, for example, breast cancer surgery, where you do level 1 and 2. Here we also include level 3, which is a little bit trickier. You include the fibrofatty tissues, superficial and superior to the axillary vein. You lift, I rarely or never divide the pec minor, but you at least lift it very high. So you really get up under the clavicula to get this level 3 nodes up here. And your aim here is to at least get 10 to 15 nodes. And this is just an example since you're a surgeon, so you can see some pictures from the real life. And this is a patient with systemic metastasis that responded actually very, very well to systemic therapy, but progressed locally in the axilla. And he was referred from the oncologist with this situation. And this is just to say that you can always resect things, and but this gives a good overview. Here you have a pec major muscle, divide the pec minor. Here we had a neurovascular bundle, the thoracic cage and trapezius muscle. But here you see you have to go all the way up here, even when you do just your regular nodal clearance. In this case, it wasn't possible to close the incision, so we put on this vacuum-assisted closure and left it for 1 to 2 weeks, and then we could close it properly. This is the inguino-femoral dissection in the groin. There are superficial nodes and deep nodes, and they should all be included. You do a lacy S or a longitudinal incision in the groin. You do your flaps, and you do that in Scarpa's fascia. There is no lymph node bearing tissue superficial to that fascia. You go up on the abdominal wall a minimum of 5 centimeters from the inguinal ligament, and you go down all the way to the apex of the femoral triangle. And the aim here is to retrieve at least 5 nodes. Here's also an example with a bulky tumor in the groin. This is the medial side, the lateral, the leg, and the abdomen up here. So how I do this, I do my lacy S incision, or just a longitudinal incision. I create a flap medially and with the Scarpa's fascia, laterally the same thing, and then I go cranially up to the external oblique fascia up here, and then I go down on the fascia to the ligament, I identify, I start with the artery because that's palpable, identify it and start skeletonize the artery and vein and get these nodes that are on the side and on the artery and vein, and go down to the end of the femoral triangle. If possible, I preserve the great saphenous vein. It's highly debated if we do anything good with that. In theory, it will reduce the rate of lymphedema, but that's actually not been proven, but I try to save it if possible. This is how it looks. This is the adductor muscle on the medial side. So I have a flap, go down to the muscle, bring it out, and then go up, abdominal wall, inguinal ligament. You skeletonize, maybe you can do it actually a little bit better than what I did here. The artery and the vein down to the apex, and here we have the sartorial muscle as the lateral boundary. So this is your the area you should remove. And in this case, it was a bulky nodal metastasis. So then you of course remove also the skin overlying the tumor to take it out en bloc. And then we come to the last version, which is the in-transit metastasis. And these are two examples of in-transit metastasis. Here we have a split thickness skin graft after previous melanoma, and here you see how these in-transit are coming. And here you have a patient with an acral melanoma on the big toe, which was amputated. And then he started to have these amelanotic in-transit metastasis on his leg. The clinical management here is to do a cytology or a punch biopsy. You do a clinical exam of the lymph nodes, because that will matter too. You redo your staging with PET CT or a CT, and you have to define as a surgeon, is this a resectable disease or non-resectable disease? I'll come back to that too, because you have several treatment options here. You can do surgery, electrochemotherapy, there are topical treatments, interlesional therapies, there are regional therapies, and systemic treatments. And I just listed the most common treatments. There are actually several topical treatment and interlesional therapies available, so that is a little bit depending on your situation and what you have in front of yourself. But I will go through these to just give you an overview of the treatment options that exist. So, surgical excision, if you have resectable disease, and what is that? I define it as if it's the first time they have their in-transit recurrence, if there are few metastases, 3, 4, 5 metastases, and if they are small, 5 to 10 millimeter. You can, of course, remove this with surgery, and it works. You should do radical excisions without margins. You should save skin, because you cannot remove this radically with radical surgery. You can just remove the tip of the iceberg here. So you do that and you just wait. It might solve your or the patient's problem actually, but there's a high risk of recurrence. Approximately 30% of them will also have a nodal disease. And if you have that at the same time, you do a lymph node dissection. And then you have to consider these high-risk patients for adjuvant therapy, and we will discuss that in the end. Amputation was historically used quite much, but now we can only see it as an extreme salvage option in very, very selected patients. However, in this meta-analysis by Reed and colleagues, recently published, they found 196 patients. And at least they had 50% with a local control. The problem is that if you amputate, there's a risk that you just will have at your end of your amputation these tumors coming again. But they had a 5-year overall survival of 24%, which is quite impressive actually. However, I have to say that we don't think that this regional treatment actually prolongs survival. The aim here is to get local control of the disease, which can become very nasty otherwise. So we do this to get control of the disease locally. Topical treatment, Imiquimod, which is sold under the name of Aldara, used to treat, for example, basal cell carcinoma. It's a toll-like receptor agonist, and it stimulates the immune system, and you apply it topically just as a cream during the night for 3 times per week. And in this, the same meta-analysis, they found 46 patients with a complete response rate of almost 50%, which is very good. But it has to been said that all these treatments are for low volume in-transit metastasis. But if you see in this patient, it worked very good. And you also see how he developed vitiligo due to his melanoma as an immune reaction towards the melanocytes. Another one is intralesional therapy, which is injectables, basically. This is PV10, which is a 10% preparation of rose bengal, a dye. And this dye is taken up by tumor cell lysosomes and causes a cell lysis. And potentially this activates the immune system. And in the same meta-analysis, there was a complete response rate of almost 40%. Another of these intralesional therapies is Imlygic or Telemogene Herparapvec, TVEC. And that is an oncolytic immunotherapy derived from the herpes simplex virus. It's gene modified, so they deleted the ICP gene, which removes the neurovirulence factor of this herpes virus and also increased tumor killing while decreasing the infection of normal tissue. And the virus also produced GM-CSF that promotes anti-tumor immune response. And there's a phase 3 randomized trial, the OPTIM trial, where they have an overall response of 32%, and TVEC is approved by FDA in 2015 for the treatment of unresectable melanoma. Another option, mainly used in Europe, is electrochemotherapy. The idea here is you use electroporation with a high-intensity electric pulse to increase the uptake of a chemotherapeutic agent into the tumor. And you can do it in local anesthesia or in general anesthesia. So you inject, when I do it, I always inject it systemically. I will use bleomycin, inject it, and then you put needle electrodes around or in your tumor, and you give this electric pulse. That opens up the cell membrane, and the chemotherapeutic agent goes inside of the cell, and then the membrane and the cell membrane closes, and the chemo is trapped inside the tumor. And this is the machine you use, the clinoperator, and there are different kinds of needles that you can use. And here you see how we insert it within a tumor. This is a mucosal tumor. There's a perfect, that's a very good operating procedure manual, the ESOP, for using of electrochemotherapy, published in 2018. And there's also a registry, the INSPECT registry. And in there you can find a complete response rate of about 48%. And here's an example before therapy after 1 month, and here you actually see the small where you've inserted the needle, and after 6 months the tumor is gone. However, all what I have talked about we use mainly for lower tumor burdens, and what we have used mostly for high volume tumors are isolated hyperthermic perfusion, and that is a regional treatment. It's for extremities, arms or legs. We also do liver perfusions and experimentally lung perfusions. It has been done, and the idea is to get a high local concentration of a chemotherapeutic agent. We use Alkeran or Melphalan, either by itself or together with TNF alpha. And since you just get it regionally in the body, you have low systemic toxicity, and you can also use hyperthermia to get synergistic effect. So this, just as an example, you have a leg with in-transit metastasis in the lower part. You do a incision in the groin, identify the artery and vein. You put in catheters, and you connect, and then you put out on a tourniquet, and you connect the catheters to a heart-lung machine. And then you perfuse the leg, and it's isolated from the rest of the body. And when you have the perfusion up running, you add your chemotherapeutic agent, and you perfuse it for 60 minutes, and you heat the limb to 40 degrees. And in this setting, you can use extremely high doses of chemotherapeutic agent, almost deadly levels of melphalan if you would have given it systemically. And this is how it looks in reality. Here you have the ingoing blood catheter. This is the vein. Here is your tourniquet, inflatable tourniquet. Here is the heart-lung machine consisting of a blood reservoir, an oxygenator, and here is the perfusion pump itself. Here is the heater, and here's a leakage monitoring system. The problem is that you can never isolate a limb completely because you also have blood vessels, for example, within the bones. So to this purpose that you also add a small radioactive tracer, and then you put a scintillation probe over the heart, so you can continuously measure how much of the perfusate leaks from the leg to the systemic circulation. And then you can adjust the blood pressure in either the leg or in the systemic circulation to reduce this leakage. An alternative treatment is the isolated limb infusion developed in Australia. Here you use percutaneous cannulation of smaller catheters, and you connect these basically to a heater and a syringe with a three stopcock valve, and you put on a tourniquet. And then you can infuse chemo during 20 to 30 minutes, but this is non-oxygenated, so this is without oxygen, basically. You just infuse it. So you just use it for 20 to 30 minutes, and you cannot heat the leg as much as you can do with a limb perfusion. And this is how it looks. These are pictures from Moffitt Cancer Center in Tampa. So you insert the catheters percutaneously, and then you just take your syringe and your three-way stopcock and infuse and push-pull for 20 minutes. If you compare these two modalities, you can say that ILP is an open procedure, whereas ILI is percutaneous. With ILP, you can get a high flow. You have normal pH and high oxygen, whereas in ILI, you have an acidotic environment under hypoxia. ILP you do for 60 to 90 minutes, where you do ILI for 20 to 30. And you can also have higher temperature in ILP, but you also have a high risk of leakage. If we compare the results, you can see that the complete response rate in the same meta-analysis by Reed was almost 60% for ILP and half, 30% for ILI. So ILP is more effective treatment than ILI, at least according to this meta-analysis. And here you have examples of the response. Here is a patient with an advanced primary tumor. And after 4 weeks, you can see how the tumor has vanished, and you also see the necrosis of a in-transit metastasis here that was not visible in the beginning due to the swelling of the leg. And this patient that I showed before, these are his the 4-week picture, and just after a couple more weeks, everything is healed, and he had a complete response. So now we have talked about local regional treatment. Now we'll move on to the systemic treatment for melanoma. And general metastasis, we just start with the staging. We stage them according to if the metastases are in the skin or lymph nodes, and that is not the regional lymph nodes, but distant lymph nodes, or B for lung, C for abdominal metastasis, and D for brain. And we also add if the patient have an increased lactate dehydrogenase level. That is a prognostic marker, a little bit unknown why, but it is. And so we stage patients with metastasis as M1, M1A if they have skin or non-regional lymph node, M1B for lung metastasis, M1C for visceral metastasis, and M1D for CNS metastasis. And then we have this parenthesis with 0, 1 if they have normal or elevated LDH levels. But now we have also a modern genomic classification of melanoma, and this actually impacts our treatment strategies concerning the systemic treatment. You can read a lot of information from this slide, but the interesting row here is the subtypes. And you see here that you have BRAF, RAS, NF1, and the triple wild type. So you can see that almost half of this population have a BRAF mutation. and then there's RAS mutation and F1 mutations. And this has to be seen within this cellular pathway with a receptor tyrosine kinase affecting a RAS protein, which points toward a RAF protein, and F1 is inhibiting this. RAF goes to MEK, goes to ERK, and it makes the cell proliferate and grow. And half of the population, half of the patients with melanoma have a mutation, this BRAF gene, which makes this constitutively activated. So this just signaling down this and makes the cell to proliferate and grow. And there are now several actually drugs that can target BRAF and also these MEK proteins. And the first one that came out was vemurafenib, and in this the BRIM-3 trial, this is overall survival. They compared or randomized patients to either receive DTIC, which is classical chemotherapy, or vemurafenib if they have one of these BRAF mutant melanoma. And then they could show that they have a prolonged median survival. However, most patients have an extremely good initial effect of the treatment, but then they get resistant to the drug, and then the tumor come back. So then MEK inhibitors were developed, and in this trial they compared single vemurafenib with a MEK inhibitor and vemurafenib, and then you see that with the dual combination you have an even better survival effect. So nowadays we always give BRAF and MEK inhibitors in combination. And that was kind of the first thing that, because there has been no, before we had BRAF and MEK inhibitors, we only have chemo as systemic therapy, and chemo had never actually showed any survival benefit at all. So there were no effective drugs concerning overall survival for melanoma patients before the entrance of BRAF inhibitors. But when we start to have this BRAF and MEK, we also have the other revolution coming, and that was the immunotherapy. And in 2013, Science magazine named the cancer immunotherapy the breakthrough of the year. And what is this? I will talk about two of these. The first one was the CTLA-4 inhibition. And this is when T cells, the immune system, are activated. You have a T cell receptor, an MHC that presents the antigen and activates the T cell, and you have to have this co-stimulatory signal with B7 and CD28. But you also have the break of the T cell, which is the CTLA-4. And when you get an activated T cell, antigen presenting cells also turns off the T cell, so the T cell will not get overreacted. But then antibodies against this CTLA-4 was developed, so you can more or less say that you removed the brake from the immune system. And the first trial that showed any benefit of this, the drug we call IPILIMUMAB, and here we see these were the first from the first trial presented by Hood et al. And what we see here is that there's no initial benefit, but after a while you see that you raise the curve here with the addition of ipilimumab. So you get a higher number of patients that seem to be long-term survivors. And this is important to remember, and I will come back to it a little bit later. PD-1 inhibition is another way, and this is you have a T cell here. They express PD-1, which is also one of these breaks. But then, of course, tumor cells and antigen-presenting cells, but especially tumor cells, are clever enough, so they, of course, have this PD-L1, the ligand, expressed. So the tumor is actually turning off the T cell when it comes into the tumor. But by inhibiting with a PD-1 inhibition, this is nivolumab, there's another drug called pembrolizumab, they work more or less the same. So they inhibit this PD-1, and then you also remove the brake, or you remove the possibility for tumor cell to inhibit the T cell. And also nivolumab compared to chemotherapy, you see, but a much more enhanced curve here. So instead of having 20% long-term survivors, you actually double it, have more than 40%. And then, of course, trials have combined ipilimumab and nivolumab, and then you're up to almost 60% or 50% long-term survivors here. So this is a revolution that has happened, and we treat our patients with this daily. James Allison, who was made a discovery of the CTLA-4, and Tasuku Honjo for the PD-1 inhibitions, they got the Nobel Prize for this in 2018, and they were very well deserved a Nobel Prize, to say the least. And here comes the important thing when thinking about immunotherapy. When you have targeted therapy or chemotherapy, what you do is that you shift the curve to the right. You have a longer survival, but eventually, if you have a patient with metastatic disease, almost all patients will eventually die. You just prolong their life. Whereas with immunotherapy, you rather seem to shift so that you have long-term survivors, and it's that end it works. And this is important to remember. And in the clinical management of today, this is from the Society for Immunotherapy of Cancer. This is for stage 4 patients with systemic metastasis. First, you have to ask yourself, do these patients, can you actually remove the tumor they have by surgery? Yes, proceed with surgery. Most often you can actually not do that. And then you have to look at the patient's performance status. If they have good performance status, independent of if they have a BRAF mutation or not, you basically start with immunotherapy. But if they have a poor performance status and are BRAF positive, you start with a BRAF or MEK inhibitor, and then you can switch to immunotherapy. Because what you want is not just to prolong patients' life, you want to get them the chance of actually being cured, which is probably what immunotherapy can do today. And this has, of course, also reached our melanoma patients where we do adjuvant treatment. And we offer patients with, in Sweden, at least stage 3B, C, D, and stage 4. That is radically resected. We offer them adjuvant treatment, and in other countries also for stage 3A. This is what they call a busy slide, but it basically takes the adjuvant trials that has been performed or ongoing and list them with recurrence-free survival. So this is the amount of patients without recurrence. And if you see here, for example, the red curve, that is the dabrafenib and trametinib, which is a BRAF and MEK inhibitor. And then you have the placebo as the light red. So the placebo arms are down here, basically. That is the light colors for all these trials. And here you can see that you have an improved recurrence-free survival. And for BRAF and MEK, it has also shown an overall improved survival. That has not yet been shown by the immunotherapies, probably due to short follow-up for these trials. But just these things that you can actually reduce recurrences by adding immunotherapy or BRAF and MEK inhibitor has kind of shifted our therapy so that we now do radical resection for stage 3 disease and then give adjuvant treatment. What also we start with, this is not in guidelines yet, but that is neoadjuvant therapy. If you have unresectable patients with large bulky nodal disease, for example, you either treat them with BRAF and MEK inhibition. You will have a very quick response. The tumor will shrink, and you will make them resectable. In this OPACIN trial, they also tested with immunotherapy, and that also seems to work with a higher proportion of patients having partial or complete response. And that is probably a future where we'll head, that for patients with bulky disease up front, we will give systemic therapy. And finally, just a few words about the role of surgery for metastasis. This is a paper from 2011 by Sossman and Vernon Sondak at Moffitt. And this is the only prospective data that we actually have. And this is again recurrence-free survival. And this is 64 patients where they did a complete resection of their metastases. But you see, very rapid, most of the patients had recurrence. And if you look at 3 year, only maybe 15% were free of recurrence. So the majority of patients had quite quick recurrences, even though you did a complete resection. And if you look at the overall survival, again here at 3 years, we have approximately 40% or maybe 35% alive. And there's no or almost no long-term survivors. And this is kind of the best data we have for surgical removal of metastasis in stage 4 melanoma. But we have to put this into the context of the new immunotherapy. And if we just go back to this nivolumab and ipilimumab trial, you see here at 3 years, you have a survival rate of almost 60%. But the interesting thing from the same publication is that if you look at the number of patients actually having a complete response, it's just 19%. And 51% of the patients actually having a partial response for a stable disease. And that means that more than 50% of the patients actually have tumors left, but they are surviving. So what we have is a situation where we have patients that are not dying from the disease, but they're having the disease left. And one of these success patients from an oncological point of perspective is this one. He had liver and lung metastasis and should have been dead if it was not due to immunotherapy. So immunotherapy was given, he had a complete response in liver and lungs, but he had these local problems. So metastasis within the abdominal wall, ugly metastasis within the right axilla, and he has received radiation heavily towards this area. And he also had a small bowel metastasis. And I think that this is kind of where surgery will play a role in the near future. This is his small bowel metastasis, and I show this just to show that how simple they are. They usually grow like this, very by themselves. It's easy to take them out, even if it's 10 times bigger. You just scoop it out, you make a small veg resection. Sometimes they have metastasis in the meso, and you just include that and you do an anastomosis. And that will help this patient who actually suffers from small bowel obstruction and bleeding from this tumor. And you can solve that with a very simple surgical resection. And you can, of course, also resect other things. It's just your fantasy that creates this. But this patient, when he was actually free of metastasis after this surgery, and he's still alive without any recurrence. And that is, of course, due to immunotherapy and surgery working together here. And this, I think, is the message for the future, where I think surgeons will have more work to do. So the role of surgery in the metastatic setting, I never forget surgery in the palliative setting. Bleeding GI metastasis, patients should not die from bleeding metastasis, nor from bowel obstruction. It's very easy to fix these problems most often. And metastasis giving symptoms in patients that are stable on systemic treatment. Consider them for surgery as well. And often the adjuvant treatment, big bulky disease that is unresectable. If you have access to BRAF and MEK inhibitors or immunotherapy, start with that and then reconsider the patient for surgery. So now I've talked for 1 hour about melanoma surgery. And if we go back to the agenda just to sum this up, the background, we've seen that melanoma is a disease all around the world. It is very different where you actually work. But there is melanoma everywhere, and it's a deadly disease. Primary surgery, we will go to smaller and smaller wide local excisions. It's important to stage them correctly. Lymph node surgery, sentinel lymph node biopsy to accurately stage patients, and so you can offer them adjuvant treatment. And if you do lymph node dissections, do them properly. Don't think it's breast cancer, think it's melanoma. So you actually have to include level 1, 2, and 3. Don't just do superficial groin dissections, do them properly, remove all the nodes, because then you will save the patient from a recurrence and a local problem. If you have patients with advanced local regional disease, for example, in transit metastasis, refer them to centers that have access to local regional treatments. There are several of them, and you have to choose wisely which treatments to which patient. Systemic treatment has changed the treatment landscape for melanoma patients. You have targeted therapies, immunotherapy, and of course also classic chemotherapy. But these targeted therapies and immunotherapy together with surgery will change the future. And here I also think that surgeons will do more and more surgery on metastatic patients. So with this said, thank you very much for listening. Thank you. And now, if possible, you can ask questions. I will happily answer them.
Professor Roger, that was a really wonderful lecture. I actually learned a lot from, some new stuff here. That one thing that I wanted to ask was about, some of the role of radiation therapy, in the era of, I looked at the curve where you talked about how immunotherapy has kind of transformed everything. But with the fact that only, you only have overall complete remission, only for about 15%, a small percentage of that, or did you say 9%? I can't remember, but so there is still a big gap here, to kind of push that survival curve up. What do you think is the main limitation here in terms of, do you think that one, there's a role for radiation therapy after surgery for this kind of, when you're treating metastasis? And number two, what do you think would be the future of this in terms of increasing the curve so more patients get survival, but not only, where patients don't only survive but have complete remission and no recurrence?
No, thank you, and great questions. And I think that I didn't talk anything about radiation therapy today, and concerning these patients with which has tumor left, of course you can also address them by stereotactic radiotherapy instead of surgery, for example. You just have to remove the tumors, and there's definitely a role for stereotactic radiotherapy. The other big role historically for radiotherapy was as adjuvant treatment towards nodal regions, but I think that has lost its interest, because now we can get good local control for most patients by giving effective systemic therapy. So that we rarely use today. So it's rather the stereotactic therapy towards metastasis that you cannot remove. That's the road there, I think, for radiotherapy. You can also use radiotherapy towards in-transit metastasis. I know they do that a lot in especially Australia because they have a high number of patients, less commonly used in especially Europe. And then comes, how do we kind of increase this survival curve? And I think that we just have to realize, of course, that the future in here will be in the systemic treatments. There has been a revolution with the introduction of immunotherapy, and I just pointed towards 2 checkpoint targets today, namely CTLA-4 and PD-1, but they are 10, 15, 20. So there will come new drugs, new therapies, and try to shift the balance within the immune system. But I also think that it's, for me, comes down a little bit basic with the surgical thing. If you have a tumor in a lymph node that is 10 centimeters big, you have billions of tumor cells there, and then you have to have billions of T cells coming there and killing each one of them. And it's just tricky for the immune system to deal with big tumor loads. And there I think that maybe surgeons can help and just remove these big tumor loads and let the immune system fix the kind of microscopic disease. But that is, we don't know that yet. We will continue trials where we actually randomize these kind of patients to surgery or continue the systemic treatment.
Yeah, that makes sense. I think one of the things I also wanted to, in my question, so in one of the last curves that you showed, so you mentioned that when you cut out when you do the surgery, there's rapid recurrence in that case. And I was wondering whether, is this local recurrence, whether if you had some kind of radiation therapy, like you do for breast cancer, kind of cure some of the microscopic disease, whether that would reduce the recurrence rate, whether that has been examined at all. But I think that you're right in terms of the future with immunotherapy, and we're actually doing some research in that area. So it was very exciting that you were able to mention and cover those topics as well.
Yeah, concerning that, the paper by Sossman, that is actually before we had effective systemic therapies. So that was just surgery, basically. And that's why I think that if we would redo that trial today, I think it's, if you combine systemic therapy with surgery, you will have a completely different outcome.
I see.
And we haven't used radiotherapy as consolidating therapy as for like breast, except for lymph nodes. But there we also know that adding adjuvant radiotherapy towards lymph nodes that increase your rate of local control, but will not affect survival.
Yeah. Okay, thank you.
No, thank you. Other questions?
Yes, Prof. Thank you, Professor Roger, for the presentation. I have a question concerning the decision of doing sentinel lymph node biopsy. Is it driven by the stage of your tumor initially, or you systematically do them for all the patients? And also another question, have you ever encountered patients with negative sentinel biopsy with metastatic diseases?
Yes, thank you. Also two very excellent questions. And the first one, who do we offer sentinel node biopsy? And we do it basically routinely for T2 tumors and more. And what we have as a lower threshold is that you want to have at least 5% positive sentinel nodes in the cohort you use. So if you have lower than that, you should not do it. And that is mainly because of theoretical thinking, but at least that the false negative rate of sentinel node biopsy by the surgeon and the pathologist is about 5%. So if you have a lower rate than that in the population you want to catch, it's no point of doing sentinel node biopsy. So you want to identify a group of patients where you have at least 5% risk of having a positive sentinel node. I would argue that the easiest way is to take tumors more than 1 millimeter. There is, you can argue a little bit more for T1b tumors where there are certain characteristics like mitotic index, which might enhance your risk of having a positive sentinel node, so you can also include them. But it's basically T2 tumors and upwards. But you also remember it has to change something for the patient. So if you have a very frail elderly patient, where the sentinel node status actually will not change anything. You will not do a completion lymph node dissection anyway. You will not give adjuvant treatment anyway. Then you can really ask what you gain by doing it. So for elderly, frail patients, I would discuss with the patients pros and cons of doing it. But otherwise, the rule of thumb, more than 2 millimeters. And I have seen, even if you have negative sentinel node, you can still have metastatic disease. It's not the perfect, it's just you have to see it as a risk. If you have a negative sentinel node, you have a better chance of not having metastatic disease, but it's not foolproof. It's not 100%, far from.
Thank you, Prof.